My name is Lee Gross. I'm a practicing primary care physician in Southwest Florida. I've been running what is now considered a direct primary care practice since 2010. So I'm going to share with you some stories in here. Also going to try to get a feel for the room and see who our audience is and sort of that'll help us kind of guide our message. I really want to make a lot of this question and answer because I think that's really where the value is in working with some of the people that have been in this field for quite some time. So, show of hands, how many physicians are in the room? Okay, so mostly physicians. How many work in the health plan field? I guess that's the balance of them. Okay, so we're going to make sure that we present enough information to cover both interests. And again, make sure everyone asks questions. Kim Corba, why don't you introduce yourself and tell us a little bit about yourself. Don't give your full show because I'm going to...
I won't.
Start. Okay.
I promise I won't steal. My name's Dr. Kimberly Corbin. I'm from Allentown, Pennsylvania. I have been practicing medicine for 20 years. In 2003, I opened my own solo family practice. I think I did that right probably at the last minute. You could still do something like that. And it was insurance-based. And I slowly built that office over 13 years. But in the summer of 2015, I decided that things were getting a little hairy and it was getting a little harder to stay independent. I did not want to work for the hospital. They were very interested in buying my office. So I talked to Josh Umber and a lot, and decided to convert my practice, transition my practice to direct primary care. So I did that in January of 2016. So I've been open now over about 16 months, and things are going great. Thanks.
Dr. Bob Nelson.
Yeah, thanks, Lee. My name is Bob Nelson. I'm from Cumming, Georgia, originally from Ohio, where I received my training in primary care. My story's a little different than Lee and Kim in that I came out of an urgent care background. I had no practice to convert, so I opened basically a mobile house call based direct primary care, no insurance billing, back in 2013. And then that got a little bit too big to manage for one person. Then I opened brick and mortar. It was February of 16. So we kind of converted that into a baby DPC practice that's still growing. So that's North Georgia, Forsyth County, just a few miles north of Atlanta.
So my company name is Epiphany Health. And Epiphany is a very strange name for a healthcare company, but in fact, we had an epiphany. And the epiphany was that we were doing everything wrong. Everything in our practice we were doing wrong. We were on this hamster wheel, and we were checking off boxes and doing nothing but treating the chart. And we were spending so much time doing nothing but satisfying the purchaser of the healthcare services, which were the insurance plans, and doing very little in terms of patient care. We were just trying to get the patients through as fast as we can. And we were trying to find new ways of generating revenue. So, when I look back at what we were trying to do, our job to keep our practice afloat was to try to run up the bill as high as we could and to get this sucker for as much as we possibly can while they're there. And one of our patients came to us in 2000, actually it was probably 2009 now, and said, this gentleman owned a heating and air conditioning company and said, my insurance costs are skyrocketing and every one of my employees sees you as their patient. Why am I paying somebody else to pay you to take care of them? Why don't I just pay you directly and I'll take out a catastrophic plan on them, and even if I pay their deductibles for them, I'm still likely going to come out ahead because they're probably not all going to hit the deductible. And that was when the light bulb went off for us and said, why are we insuring primary care? Why are we using such an inefficient model, an insurance mechanism to pay for the most basic aspects of healthcare delivery? If I wanted to give you $1, is the most efficient way to hand you the dollar, or is it to give it to you and to pass it along and say, everybody take a penny out of that dollar, and by the time it gets to you, you have to have 30% administrative fee to process that dollar? That makes zero sense, but that's what we're doing with all these tiny little health claims for primary care services. And so my colleagues and I got together and said, what do we need to do to carve this practice out of the third-party payer system? And we needed access to affordable labs. We needed access to affordable imaging services. We needed access to, or at least some price transparency to help guide our patients through this broken system. And so we ended up creating, which is what is now being called direct primary care, which was a membership-based medical service. We eliminated the fee for service in our office and charged a flat monthly fee, and I'll explain to you a little bit later what that flat monthly fee is. But then we created a network around us of very steeply discounted services with price transparency, again, to help guide our patients through the broken system. So this is why we're all here, because the free market brings down the cost of services. Everybody knows this. Everyone knows that technology improves care delivery, or everybody knows that technology improves service. Everybody knows that technology brings down cost. And so we have this LCD screen that comes to the market, and before you know it, it's a Black Friday special at Walmart. That's the free market that we all know and love, and we want to fight to bring to medicine. And what we see in medicine is that people are saying, no, you tried the free market, it doesn't work. No, we've not tried the free market in medicine. What we've tried is a crazy system of price fixing and price obfuscation, but we've not exposed any market forces in medicine anytime, at least since the 1960s. So if we're putting all of healthcare in a box, and we're going to call that box health insurance, and we've got to sell that box at one price. Okay, and in that box, we're going to put our nice, affordable primary care services, but we're also going to bundle in with that a 3-month catastrophic hospitalization. We're going to put some end-of-life care in there. We're going to put in a coronary bypass surgery. Think of the most expensive stuff you could possibly imagine happening to a patient, and we're going to put that in that box, and we're going to sell that, and we're going to say, this is what you have to buy to access the healthcare system. What it does is when we're mixed in with that, it artificially raises the access point to the routine care that most patients need. But when you split the primary care services off, we actually become very affordable and become quite a powerful tool at accessing the healthcare system. So this is a Rube Goldberg toothbrushing machine, taking something that is extremely simple and making it extraordinarily complicated. And that's basically what my life was in the insurance-based practice, is doing everything to treat the payer, but doing very little, and none of that actually satisfied the goal, which was patient care. But what we've done is stripped out all the unnecessary stuff, and now we're just a straight, we spend our time taking care of the patient. We're not using our staff wastefully to treat the phones, to treat the electronic records. So we charge for that as $60 for an adult, $25 for one child, and $10 a month for each additional child. And after that, we don't charge anything for the services in our office. We don't charge copays, we don't charge deductibles. If it can be done and is medically necessary, it's done at no additional charge. We've also, again, put together a network of services. We buy our labs wholesale and pass those lab savings along to our patients. We have physical therapy that we have for $35 a session. It's a little bit small, but basically this is just a complex way of saying that everything we do is included. So if you were to go to the lab and you had no insurance, oftentimes you'll pay $400 or $500 for those labs. We'll get those labs for $45. And it's a simple conversation with the lab. When we set up those arrangements, at least the first time I did, is I said, I'm going to send you 500 self-paying patients. Would you like to track down each one of them individually and try to collect from them? Or would you like me to collect the money up front and send me one bill for 500 patients and I'll pay it for you? So the money's already there because I've collected it in advance. And if so, what can you sell it to me for? And we were seeing 90 to 95% savings on labs. Same thing for the imaging centers. We'd go to the imaging center, the independent mom and pop imaging centers, and say, do you own your MRI machine? And if you do, is it running all day long? If not, what would you sell me an empty MRI slot for? If I told you that the patient was guaranteed to pay you at the time of service and you didn't have to wait 6 months, didn't have to get prior authorization, step edits, and do the test and get it denied after the fact, what could you sell it for? So to give you an idea of the types of savings, we're seeing about $25 for a chest x-ray. Our CT scans are about $175. Our MRI at $225. I'm not sure I've seen anybody beat that anywhere in the country.
That's, I think, the best price.
And we'll share some interesting anecdotes about that a little bit. But we now have a hospital on board. So, we're in Oklahoma City. Everybody, of course, knows about the Surgery Center of Oklahoma, but we are now matching the Surgery Center of Oklahoma's pricing in a hospital in an inpatient setting in Florida right now. So our bundled colonoscopy price is $1,000. That $1,000 colonoscopy includes pathology. And so why is that important? It's important because if you go in for a colonoscopy and you have a nice clean colonoscopy, you're done. You stroke a check for $1,000, see you in 10 years. If you have a biopsy and you have anything going on in there, that $1,000 colonoscopy is now a $2,000 colonoscopy with one snip. And so that bundling in of the pathology makes the world of difference certainly to the payer of those services. So this is an actual hospital bill of a patient of mine. I don't expect you to read this, but I show it to prove that it is an actual bill. And that bill comes to $20,000 for a patient that went to the ER for abdominal pain. Now because it's so easy to get in to see us, right? Get in to see us. It's stat labs, stat imaging services, see me within hours. In fact, oftentimes you can see me quicker than you can get seen in the emergency room. And so using our prices, what could it have cost, what should it have cost, the same exact services done in my office, we would have charged a patient $301.29. So now, I had this conversation already earlier today is, what the insurance company would basically do is they'd mark that down to $5,000. You'd get an explanation of benefits that says, congratulations, we're so glad that you had XYZ insurance, because now that bill is discounted to $5,000. But what you don't know is oftentimes that plan saves a percentage of that $15,000 discount, and in essence, what you've just done is pay $1,000 a month for coverage to pay $5,000 for $300 worth of medical care. That is really important in the self-funded world to understand that concept, and many times it's actually against your contract's agreements to actually go to the provider and find out what their actual charges were on this, and there are gag clauses in there. I think Ralph Weber talked about this in Las Vegas with us a few weeks ago.
What was the diagnosis?
Oh, for this?
Yeah, but what was the diagnosis?
What it ended up being?
Yeah.
I don't know, this was years ago. I don't know. Probably gas.
Yeah, exactly.
So this is a great story. We've had our first case of inbound medical tourism into the United States for affordable medical care. The doctor in the upper left-hand corner is Dr. George. She's an ear, nose, and throat surgeon in Atlanta. She went to Antigua on a mission trip. She does trips down there, and she diagnosed a patient with thyroid cancer. And the patient had no coverage, was looking around for care, and looked into San Juan and was quoted $100,000 for a thyroidectomy. And Dr. George got her in touch with the Surgery Center of Oklahoma and said, what can you do for her? And Dr. Smith said, we can do the surgery, but she needs about 6 months of preoperative and postoperative care. She needs, pre-op assessments, she needs imaging, she needs blood work, she needs an endocrine consult, and she probably needs medicine, she may need radiation, and so we need a little bit more around what we're gonna do, and so do you mind doing it, because Florida's a lot closer to the Caribbean than Oklahoma City. So we agreed, and the patient flew to Florida. We did everything we needed to do on our end, communicated with Oklahoma City. She flew to Oklahoma, had her surgery, and came back and did the postoperative work through us. We cured her once-in-a-lifetime catastrophic event for under $10,000. So 10% of what she was quoted just for the surgery alone. So if you're a self-funded plan or you're trying to put a program together and you have a PPO product that you're delivering to your employees, let's just look at a typical family of four as to how this would look over time. And that red bar or the red line is what it would cost for a typical PPO. And if you see the latest Millman statistic, they blow your mind as to what these plans cost now. But we're talking about $258,000. It would be the cost over 10 years, assuming there's no inflation over that 10 years, which we know there's not. But if you take that black line and say, we're going to go ahead and take a health sharing ministry, and we're going to bundle that with a direct primary care practice. So now the health sharing ministry is going to do your catastrophic, your stop loss, and the direct primary care is now going to be your basic coverage that you need to manage your diabetes, your hypertension, your asthma, your high blood pressure, your cholesterol. And so now we have your coverage and your care for the same, or bundled into one program for $72,000. The net savings of about $185,000 over 10 years. So some of you say, well, the patient's going to have money out of pocket for their services because these plans don't kick in until their deductibles. even if they took out a $10,000 catastrophic deductible, if they spent $10,000 a year over 10 years, we've still saved them $85,000. So even if they're coming out of pocket, so what we encourage our patients to do is put that money you would have paid for a healthcare plan into an account for yourself, basically sort of self-fund your own insurance. So what we're trying to do is we're trying to simplify this relationship, and by simplifying this relationship, we're managing to take a lot of the useless costs out of it, streamlining it, and making things just much more patient-friendly, much more practice-friendly. Happier docs, happier patients.
Mm-hmm. Amen.
That's my contact information. You'll probably see a little bit more about that today. In addition to doing this, I also run the Docs for Patient Care Foundation. We're a nonprofit educational foundation that promotes healthcare freedom in the country, the all-physician board, so feel free to contact me.
Lee has just laid the foundation, at least the economic and practical foundation for, I think, direct pay in general. And I know this is a DPC conference, but a few years ago I had the opportunity to talk to one of the doctors, Bliss, and I think we all have our view probably about what happened with Q-Liance, but we owe them a debt of gratitude for paving the way and showing us what was possible with direct primary care. And the conversation was that, I've tried to make the point that we need to look at DPC as part of a bigger ecosystem of direct pay and non-third-party care that does not, inflate everything it touches and instill healthcare with a lot of perverse incentives that we have now. The response I got was that, well, we need to focus on DPC, and it kind of, I guess my message is we need to look at DPC as part of a bigger puzzle. One component of building a new market. I'm a firm believer that, and Lee is going to give a legislative talk, so I'm not going to steal his thunder, but I'm a big believer that we're not going to do this with just regulatory and bureaucratic fixes and legislative fixes. This is going to have to be a grassroots market that rises up alongside of the current system until it is so unattractive, until the current system is so unattractive that everybody just turns their back on it and says, why the heck were we doing this for the last 55 years? So, that was and can I ask how many physicians are non-DPC or have a traditional practice, urgent care, ER? Wow, not too many. I'll just ask, how many people, or what would you estimate the cost, the insurance CPT billed code, excuse me, for a CBC would be if a patient walked into a lab with a prescription and the lab billed it to the insurance, whether they had coverage or whether they met their deductible, what would that CPT cost be? You're closer. Well, this was 3 years ago when I did when I called the lab and told them the CPT codes I had for these certain prices and asked them. It was anywhere from 72 to 120, and that was Quest and LabCorp. I mean, you could go on. I mean, every lab's going to be about the same. My cost $4.44. I mean, Lee's slide said the same thing. So we're dealing in an economy that's just in the stratosphere, and it's cut off from the rest of the economy. The reason it works the way it does.
I was looking at Lee's slide about the ER charges, and actually, this morning I awoke to a phone call from a patient, an elderly patient. Actually, that's the ER. I'll have to step out for a second. an elderly patient who lives by herself. She's very functional. She was in the hospital 2 weeks ago for unknown etiology of pulmonary emboli. She was sent home. I made sure I saw her before I came here, post-op visit. She's very stubborn. Her daughter-in-law was with her, and I told her, I said, if you get short of breath, Alma, you have to go back. Don't drive yourself. Don't call anybody. Make sure you call an ambulance. Well, she called me this morning short of breath. So I was on the phone with the ER. But in a case like that, if she... I was able to communicate with the ER. So there's the cost part of it, but there's also another part of direct primary care that's bringing back the doctor-patient relationship. The cost is a huge part of it. But for that affordable cost, they're getting their doctor on the phone. And they're getting their doctor, calling the ER doctor, saying, so this is what's going on. The doctors love it. Sometimes I feel like the ER doctors or the hospitalists don't want to be bothered talking to us because they're so busy. They actually are really embracing my ability to communicate and our ability to communicate with them about patients. It makes the whole process go more efficiently for the patient, whatever their illness may be. There was another case, a situation where I had a patient who was directly admitted from my office. She was able to be driven by her family member, but I don't know, most of your hospitals offer direct admission where you can bypass the ER altogether? Yeah, no? Okay, so, yeah, well, we can actually call their triage center and then I get the hospitalist on the phone and I can arrange for direct admission. So if the case isn't that serious, doesn't need the ER or safe transportation with 911, that I have arranged for direct admissions from my office. So the family member takes them right to the floor of the hospital. You avoid the ER and that bill altogether. But that's another part of direct primary care, is our ability to call and communicate, and the time. So I have 30 to 60 minutes per patient, depending on what they're coming in for. That gives me a lot of time to step back and assess the patient, do the right thing, and in turn, that lowers costs. That will lower cost. Instead of a knee-jerk calling 911 for that patient, I assessed her. She was stable. Vital signs were stable. Spoke with the hospital, and then arranged a direct admission. So that's another part of this, in addition to the cost that we've lost in primary care. And I think primary care is having an identity crisis right now because we have the mid-levels in there. We have to see a patient in 7 minutes. We've kind of lost our identity, and direct primary care, I'm old enough to remember what it was like before all of this happened. I finished my residency in 97, med school in 93, and worked my first job, and it was in 97 that the first E&M coding came out from CMS and Medicare, and then after that it was the snowball effect. But I remember what it was like to be able to spend more time with the patient and to not have to talk about cost every single visit, even in the fee-for-service system. I was talking about cost every single visit. So this is what it's brought me back to where it used to be, to a degree, and the patients are really liking it. They're very satisfied. I'm very satisfied. I feel like I'm practicing primary care again. So.
Kim, do you have the ability to follow them and look at their chart day by day? Or?
No, because I'm not part of their EHR system at the hospital. But I do call the hospitalist, and they're always happy to talk to me, or the resident. The residents love talking to me. They probably don't talk to many people outside the hospital.
That's true.
Anymore. No, yeah. Or that are nice to them, yeah. This is true. And I have had them actually call my office with updates, which was really nice.
That's unheard of.
So show of hands, I asked earlier how many doctors in the room, how many doctors are actually practicing DPC presently?
Wow.
Okay.
Amazing.
So there's a lot of experience in this room, so we definitely want to open it up for questions, comments. Any of the doctors in the room work for Q-Liance at one point? Yeah, so I think that's sort of the elephant in the room, is when you have a big, high-profile failure like Q-Liance is doing sort of a post-mortem and finding out what exactly happened there, and am I next, and what am I doing? And although I don't claim to have any inside information in terms of I've not analyzed their books, but sort of the big story was that they did have a relationship with Centene, which was a Medicaid managed care company. And it was a wildly successful arrangement. They saved the state of Washington a fortune in healthcare claims. But the state of Washington had a clawback provision that said, if you don't spend the money on patient care, we're going to take it back. And so the money that was promised to Q-Liance to provide the care was taken back by the state of Washington because they didn't spend the money on patient care. And so that's just something that snowballed and they never completely recovered from. So I think one of the important things is always recognizing why this works so well, and it really is that relationship between the practice and the patient. And anytime things start to get in the middle of that, the boundaries start to get blurred. And I'm not saying that you can't design a successful system, you can't design a successful business arrangement through a company. But at the end of the day, if your primary focus is not making sure that relationship between the physician or the provider and the person receiving those services is clear and transparent, it creates unique challenges that distort the system.
It matters. Lee makes a great point. It matters who the customer is. In other words, there's a lot of parallels when you think about between the old capitation models, for those of you that are old enough to remember living through that disaster. There's a lot of parallels to the capitation model. You get paid a lump sum to take care of so many people on a quarterly or yearly or whatever it was, but it failed miserably. And for decades, the customer in healthcare has been large network carriers and the government. And so it matters who the customer is, because government and health carriers, they have different priorities, different incentives than the customer does and the doctor does. So all of that matters a lot when it comes to why, as Lee said, why DPC can be successful, I think, when capitation wasn't.
Go ahead and open it up to questions. If not, we'll just keep on keeping on.
So along the lines of where you are right now, do you have ideas of how do you keep that relationship clean, especially if you're working with employers who are willing to send you patients? How do you keep, and then all of a sudden that employer says, I'm going to shift over here, you lose that complete patient base. So how do you keep that so it truly is between the patient and the provider, and you're not as vulnerable as Q-Liance was in that situation?
Do you have business agreements that you want to address that? I can address how we deal with it.
I do, but I have so many really micro businesses, family businesses, small business. I don't have a huge chunk of a percentage basis from any one employer. So I don't have it, it wouldn't impact me like that. So somebody else should speak to that.
Yeah, so, our biggest thing we're working with right now is the city that we practice in. They want to offer direct primary care as an employee benefit. So that's 550 employees and their family members. And we've basically told them, we don't want you to necessarily sign and pay for the patient or for your employees. We want you to put the money in an account and have them pay for it. That way they can use their own dollars and shop around on price and value, and that still creates the dynamic within the practices where we have to compete on price and quality, and the patient has to decide whether that money they're paying out of their own pocket has value to them. The first question that I had when I gave this presentation in Washington in 2011 was, what happened? At the time I was charging $80 a month. My prices have gone down since then due to the skyrocketing cost of healthcare.
Yeah.
They said, well, what are you going to do if somebody sets up next to you and charges $40 a month? I said, well, we'll have to compete on price and quality, and we're not going to have to do any sort of crazy reporting metrics. The patient's going to have to determine whether this is worth their money or not, and if not, they're going to leave. That's a concept that is challenging for people in health plans to get. It's a challenge for people in government to understand that the patient is too unknowledgeable to be able to choose the proper health care and to choose whether they're getting good health care, but we let them choose their homes, their neighborhoods, their education. Why not let them choose their healthcare provider.
People tune their shopping sensors, right, to healthcare. They, and that's a myth. I mean, both on the left and the right, I think that healthcare, that we have such a information advantage as physicians that people can't understand and make decisions. We're there to collaborate with them, help them through that process, but they do. And the whole thing about the question about employers brings up the whole Cobra issue. And I think Lee is right. If the patient controls those dollars, or at least a portion of those dollars, if they change employers, or if the employer does an about-face and changes the direction of the plan, those folks could continue on at the same price and with very little change probably in their out-of-pocket. So DPC, if it's done right, probably obviates the need for at least some of the expensive Cobra plan.
But I understand your question about the fear of a mass exodus from the practice of a large employer base. And I cap mine at 300, my patients. I will go probably a little higher at some point. I think my area needs to, I'm the only DPC in my area, so I think there's still a cultural adjustment going on. But right now I'm very happy at 300. But if I were to take a panel of 50 employees from a small business, and I have a lot of patients who are owners of small businesses. They love this model as the owners, and they have talked to me about coupling it with something for their employees. But I would never take more than probably 10, 20 employees at the size I'm at now, because I couldn't handle 50 leaving my practice as far as my overhead. Now, the larger DPCs might be able to handle that a little bit better. But I also think it depends on the size of the practice. Like what size employees do you want? Do you want 20 or less, or are you a larger entity and can handle more than that? Some of these DPC practices are over 700 patients now, and they could probably handle an employee base of 50 with the fear or the realization that they might at some point cancel. And it wouldn't hurt their bottom line too much. So.
It's tempting for a high growth, or when you're in the growth phase, to take a big chunk of patients to get you to where you need to be, but that may not be the best strategy. Just like with insurance, you got to look at, when you're in insurance contracts, you have to look at the demographics and which contracts, unfortunately, which pay, which don't, and all that, and decide how much Medicaid or Medicare percentage-wise. I think we're probably going to go that same route with DPC.
So, I think one of the things that's important is, again, you can scale it if you want to. If you want to go with a large employer, we were just on the phone with somebody that signed up a company with 15,000 across the country. It was a crazy deal that they worked out, but hopefully it works for them. One of the things that works for a lot of these people is you want to get away from a lot of the reporting requirements and data collection. I promise you, if you're working with a large company, you'll be doing that. They will want data, and they rightfully expect data. So to enter into that relationship and not expect to be collecting data and analyzing downstream utilization and being able to provide them, where are you saving them money and why are we using you? Then I would caution you, that's not a relationship. If you don't expect that down the line, don't start down that path to begin with, because it's coming. There's a question right here. I want to get a microphone so we can get this on the video.
Yeah, make it Scott.
1 second.
Hi, Lee. My name's Kyle Rickner. I'm a direct primary care doc here in Oklahoma City. We opened a year and a half ago as well, and things have been going very well for our practice. We now have 3 doctors in there. I think we're approaching 1,600 patients in the practice, and we're looking at growth opportunities and becoming multi-site practice, and we've been looking at what other people have been doing around the countries. And one of the things I've been reading a lot about, and I wanted to see what your insights and comments were on the Our Health deal with New Jersey state employees. It was a massive deal, and I'd like to hear if you have
Yeah.
I'd like to hear any insight that you have on that.
You? I have the mic. So Our Health is coupled with 2 insurance providers in New Jersey, and the product is being offered as part of their plan, which I didn't like the way that sounded to begin with, but they have been around for a while, Our Health. They're in the greater Philadelphia area in South Jersey, and they had before they made their big announcement that they had gotten this deal with the state of New Jersey, they had about 100 practices between general greater Philadelphia area and South Jersey. Now there's been a big push to get more docs, and we have some DPC docs in Jersey, and I have some friends over there. And I've been hearing that they're trying to hire. It's very hard to hire. They set up the DPC office and they put the doctor in it. They do all the marketing. And I spoke to them directly at the Pennsylvania Osteopathic Medical Association POMA meeting last spring. They set up everything and do the marketing and put the doctor in. But it's hard to get the doctors in there. I mean, so they are going to. They're just not a big pool of doctors that they're able to hire for these jobs. So what they're doing is they're going to existing practices and having them carve out a DPC inside the fee-for-service practice.
So setting up a hybrid.
Yes. So
within an established practice.
Right. Mm-hmm. So I'm not sure how that's going. And I think it's just with those insurance products that those doctors, I don't know if they don't have to opt out because they're participating because the DPC is part of the insurance product.
Well, if they send the Medicare eligible patients and they're charging Medicare,
Yep.
They're in trouble. Yeah.
Right. So there's a lot of gray things going on that we're not sure about. I did hear that they're having trouble scaling up. And New Jersey's gonna want to watch those numbers, like the costs. So I don't know what their patient base is like or how many have experienced the DPC product that are union and state employees over there in Jersey. So there's a lot that we're not sure of what's going on with that.
But if you look at like Catherine Restrepo's data from Union County.
Yes, then that's different.
So Union
That's
County,
totally different.
they offered this as an option, as an optional benefit to their employees, and in the first year had about $1.3 million in savings with improved patient satisfaction.
But they did it right. They did it right from the ground up, and Catherine did a great job, and she's still tracking some of that data. In fact, I had the article pulled up last night, and I was looking at it again.
Yeah, I've looked at that closely, and I agree. I think they did it right. The numbers on the Our Health deal did not make sense to me. There's 550,000 beneficiaries.
I've seen all kinds of different numbers.
And they are allowing DPC practices to have 1,000 patients, which seems a bit overwhelming, to be honest.
Yep.
That's a lot of doctors. I mean, that's the equivalent of the number of doctors of total DPC docs in the entire United States to cover that plan. So I wasn't sure how it was being implemented. When you meant it was, when it was combined with an insurance product, is it sort of a catastrophic surgical hospital plan and then the direct primary care is tucked in with it? Is that how they've done it?
I'm not sure about the plan details. I can't comment about that. I wish Phil was here. He might know more.
You probably will.
All right,
He
thank
knows
you.
a little bit more about everything.
Yeah.
Yeah.
I'm tending to think it's just a regular I don't think it's catastrophic.
Union County, for those of you who don't know, it's Union County, North Carolina, is it not? Yeah. And it was their, obviously the county's plan, and I think it was Paladina that they contracted with?
Yes.
Yeah, so it was a little different, but it wasn't an on-site clinic necessarily, was it? But they had some facilities on site, but also elsewhere, if I remember.
They had both, yeah.
Yeah, and so they went from a qualified, I think what they consider a high deductible plan, and then they kind of transitioned that, and they offered both the more traditional and then the DPC component, and I think that's where their savings came from. I'd throw a question out to the audience related to your question and the thing with Alliance and Union County. Is it possible to have employed DPC docs when you're in those growth phases if you have the influx of patients? Can you employ somebody and then transition them to their own panel, which they're responsible for growth? I'd like to hear Lee's and Kim's opinion, anybody else in the audience too, because I think we're going to see those kinds of things come up frequently.
I mean, we have when we sign an employer agreement, we always have the patient sign an agreement too as to how they can continue that relationship in the event the employer ceases the plan. And so there's already something in the contract to say what exactly is involved in taking that over. So, just like if you like your plan, you can keep your plan. You like your doctor. It doesn't matter if your employer switches from us or not. The patients can stay. It doesn't matter if they change jobs or not. The patients can stay. We just explain how that's possible and what needs to be done to make that work. One of the other things I think that we're going to start to see is states are going to start to look to their Medicaid programs and seeing how they can't maybe hitch up to DPC practices. So when you look at this debate in Washington over the free market reforms and block granting money to the states, they're looking to you guys. And that's what's in their mind when they're saying we're going to block grant this to the states, is they're thinking direct primary care. They're not saying those words, but that's what they're thinking. And so, you guys that are doing this need to understand, how this needs to work for you and to drive this conversation correctly. Because, even one of the folks I think that gets this more than most, Senator Pat Colbeck of Michigan, I mean, he understands this. He understands the dynamics. He's studied it. He's been in the practices. He's met a ton of folks doing this. Yet he still won't release control of the healthcare dollars to the patient. And he and I go round and round about it, and it terrifies me that his Medicaid program may not fail or may not be successful for that reason, and that the state wants to control the money, which is going to mean lots of reporting requirements for the practices back to the state to justify the money that they're receiving, as opposed to my suggestion to him was just like food stamps, put it on the EBT card. You don't go and follow the patient around in the grocery store and look at what they're buying. Just track it through the EBT card. And I, as a practice, if I have a patient that comes in with a credit card, why do I care who funded it? It makes no difference to me. And so if the patient controls the dollars, then again, the patient has control over whether they're getting value for their money, and they control it. It just seems like a much cleaner relationship. So,
Well, this is a bigger concept of the whole public policy about how you fund things, whether it be healthcare or other. The concept that John Goodman has pushed for decades. It's that the public money should follow people. Money should follow people, not programs and insurance plans. So, Lee's exactly right. If they control that, and that's the whole debate about tax credits versus tax deductions, and in giving everybody a baseline. And a lot of people say Medicaid should be the public option. I don't want to get too deep in the weeds on this, but if that was true, then these people could decide to opt in or opt out and use those dollars to, say, purchase direct primary care or purchase a Medicaid-like policy. So I think and Lee is going to give a policy update at noon, but I think anybody with influence or contacts at their state levels should really be, pressing them on that.
I also think it's really important. I'm sorry, I saw your hand. One second. I think it's really important for the patient to, and everybody's kind of touched on this, pay us directly, rather than the employer or the state paying us. There's definitely more engagement. There's more accountability. The patients do have a higher level of expectation with their services, so if they're paying directly, that it just engages them rather than somebody else paying and them still having a high level of expectation. It's different. It's a different dynamic when they're actually paying you themselves a monthly membership fee.
I know there's a question back there, but on this topic, this is interesting. So again, I mentioned we have this relationship with a hospital. We have a bundled price now for total knee replacement of $25,000. That includes the implant, that includes the surgeon, anesthesia, includes the facility fee, and it includes a week of inpatient rehabilitation. Now, that's about probably what Medicare would pay for the same exact service. But when we sent our patient to this hospital, they were so excited because the patient got all fresh linens, brand new sheets. The patient got a room full of flowers. The patient got room service. It was catered because they paid their bill directly. It was the craziest thing I'd ever seen. I mean, this patient was, when I worked at the Cleveland Clinic, the princes and sheiks were not treated with that degree of respect as this patient that was stroking a check for $25,000 for this surgery. So it was fascinating that the same exact amount of money just paid by a different person completely changed the dynamic in the hospital. There's a question in the back.
Do you have any concern, you mentioned the analogy to capitated, do you have any concern that somewhere down the road, state insurance departments might come in and say you're running an unauthorized insurance company? Particularly if you put particularly if you put a dent in the big healthcare plans, and they start to put pressure on the state departments to do that?
Did everyone hear the question? The question basically was, do you have a concern that you're basically going to be accused of running an illegal insurance company? You know, you're charging a flat monthly fee for unlimited medical care. Aren't you an insurance company? Aren't you a risk-bearing entity? And are you concerned that as you're making, you know, dents in the insurance company's bottom line as we grow more market share, you know, going to get shut down? Yeah, that's a legitimate question, and I think that's why there's been such a push early to get protective legislation, which is now available in 23 states. And I'm going to talk about this over lunch, so I don't want to get ahead of myself. There's a hand waving vigorously in the back of the room.
Can I ask one more? Can I expound on that really quick? Did you also mean, despite having state legislation in place, if protective state legislation, did you reference also the possibility that insurance companies will start to get their panties in a bunch a little bit more, because even though we're protected by state legislation, we're putting a dent in their bottom line? Are you referring to that as well? Yeah. Right. Well, and we've had talks about that. I'm sorry. We've had talks about that. I think the worst thing that they could do, as long as you have state legislation, which we're working on, and even if you don't, the worst thing that they could do is send in somebody to audit you.
They could send a cease and desist letter.
They could send a cease, but you can fight that, which is another whole can of worms. That's why it's so important to get the states to get the legislation. I think we've had 6 states pass it this past calendar year, which is amazing.
Mm-hmm. There's a comment in the back of the room waving vigorously, I think, on this topic.
I would like to comment, but almost 5 years ago, we were open about 6 years. 5 years ago, the Department of Insurance, I'm from the wonderful state of California, where we just love private care and things like that. But the Department of Insurance and the Department of Justice tried to shut us down because the insurance company was afraid of us, what's going to happen.
That's right.
And
yeah.
Literally, it scared the crap out of us, really. We won that and got an apology from the Department of Justice, all right? And don't be afraid. Just do not be afraid. And if anybody has trouble with that or questions, come and talk to me. Because seriously, we are in the right, all right?
Thank you for that comment.
Mm-hmm.
Yeah, I'm an insurance guy, so I'm going to comment on, I travel around the United States. There are states that are embracing DPC in a great way, and I've actually had conversations with various departments of insurance, Georgia being specific. Texas is a good state. Watch out for your states. The various states have different perspectives on this, and it's interesting how the adverse insurance environments are also adverse DPC environments.
That's right. Yep.
So be careful where you go play, but at the end of the day, some of you are in states where where you're not going to have any adversarial problems. In other places, where you're going to get hit from the insurance people is when you start tagging into their networks and start stealing docs from their networks. That's when you're going to get the biggest pushback, because they're going to come at you with a vengeance, and it won't be the legislators, it'll be the networks, the people like the Aetnas and the Blue Crosses of the world.
You mean taking their doctors to hire?
Yes, pulling their doctors out of their networks and bringing them into DPC.
And it'll be surrogates from the big health system and the
Right.
employers that will do that work for them.
Absolutely.
Well, it's interesting. I think the growth rate is also directly proportional to legislation and friendliness of the state. I think on a national level, we're seeing growth is very variable around the country and varies widely between states, as does the public's perception of the expectations on what DPC is. And I think that it's definitely growing faster and is perceived in different ways in different regions. The Midwest is growing like crazy. The Northeast, we got patients beating us up, expecting the sun, moon, and stars, and we have to put boundaries in place and say we're practicing still within the scope of primary care. And I think they're just beat up because of the cost of the system and the inefficiencies of the system. And they come in and want us taking off their melanomas and doing their colonoscopies and managing their chronic kidney disease before they go on dialysis, and so that's a really good point, and that's why it's really we really need to keep pushing. If your state doesn't have DPC legislation and you're in support of it, start pounding the pavement.
Yeah, there is some model legislation out there with the DPC coalition. If you wanted to start working with your state, make sure that you have your ducks in a row before you start taking things in there, or before you know it, your legislation will be hijacked, and it'll be the least friendly DPC state in the country. The issue that we ran into in Florida with the insurance companies is, what they really feared is us double dipping. They don't want us charging the patient and then charging the plan. And so that was sort of one of the deals that we kind of worked out behind the scenes with the insurance lobby, was that, we were going to have legislation in there that said you will not bill the insurance company for services you're providing that are included in your plan or included in your membership. So that's where organizations like MDVIP, they sort of walk a gray zone where they're charging a membership fee to the patient, they're charging the plan then for the services that are providing in the office, at least in most practices, not all of them.
We hate doing anything with the insurances so much that even there was discussion on Facebook about they send you code. The insurance companies have a patient. A lot of our patients have insurance. In fact, there's a study a small survey that we did with some DPC docs. We're going to repeat it in 6 months with Catherine Restrepo from John Locke, and hopefully more docs will respond. As time goes on, they'll get more comfortable. Nobody wants to report anything. But this was all industry data. Her average was about 58 to 60% of our patients in the DPC practices that responded have traditional insurance. Well, we still occasionally with those patients get a form where you have to fill out some CPT codes, or they want to know, are you tracking their this and their that, and we're all like, trash, shredder, yeah, sorry. And I'll call the patients and I'll say, do you want me to fill this out? I don't know if this is going to, you might want to call your insurance company and make sure it's not going to affect your premium. And they all tell me, shred it. Even the patients are like, don't deal with it.
Mine's higher. Go ahead and take her question. But I wanted to ask, how many, I probably have 75, 80%
Did you respond
that
to
have,
the survey?
I don't know, did I?
You should have responded.
That have traditional insurance, including high deductible plans. What other DPC docs, do we have any ratios? Do you track that?
It's hard to track it too, unless you.
Sometimes they don't tell you. It doesn't even
sometimes I don't even ask.
Doesn't even come up, right?
I don't even ask.
I've asked. Yeah, go ahead.
I think my biggest concern as far as the future of DPC and the threats to my practice are these highly managed HMO programs. And I recently got a new patient who had an insurance plan. We don't even look. I don't even know what the insurance plans are anymore. I've been doing this since 2014, so I'm not familiar, but the gentleman had a stroke, and so I needed to make a bunch of referrals, and he needed a lot of care, and I suddenly found that I wasn't able to do anything for him. I couldn't make a referral. I could only prescribe meds.
Do you have a really good friend who's a family practice doctor
Yes.
down the street? Okay.
Yes, and so now he has a primary care physician, a real one,
Right. That's
so
what I do.
Yeah, exactly. So what do you see? What do you think is going to happen with that? And my concern is that's how we're going to get pinched. That's how they're going to go about it. It's not going to be legislation. It's going to be insurance companies and there'll be plenty of uninsured patients or patients that choose health shares or whatever. But what is your?
I'd like to speak on that. It circles back to what I said initially about DPC being an island. This has to be part of a larger direct pay total paradigm shift about the way we look at healthcare and the way we fund healthcare. And we have to have the specialists involved in a certain way. Now, it may not be a membership model. It may be a 110% of Medicare fee, cash or something, or working out. I know Keith tells a story about when he does cases at the surgical center that might be somewhat complicated. It might require a day or two of hospitalization. He collects a deposit, essentially, for those kinds of potential critical complications. So in other words, we've got to get the specialists involved some way and build these networks around DPC, or we will, and I run into that all the time. You feel very powerless to help these people, and then you feel like, well, they've just got to go back into the old system and make their way the best they can.
Yeah, so there's a couple other things. So of course, dealing with the HMOs is always going to be a challenge. I mean, if you're not in the network trying to deal with HMO patients and interact with them and get patients referrals is always going to be a nightmare. And I think probably a few people see this more than Jeff Gold up in Massachusetts, which has heavy HMO penetration. Now this is where the lawmakers are starting to think that they have the answers. They're starting to put in like any willing provider statute. So if you're willing to work with the plan and you're willing to follow their rules on referral, then shouldn't, even if you're not in network, be allowed to guide their patients through.
Isn't that in some of the state legislation too?
It's tough.
I think they just wrote it into our Pennsylvania draft.
It's really tricky. I mean,
Yeah,
I just got an email from a lawmaker in Ohio that wants to make Ohio the most direct primary care friendly state in the country, and proposed all sorts of stuff with, again, demanding that the insurance companies must accept referrals from the doctors that are in network. They're not even a DPC friendly state yet, so to go from not having any protection to we're going to now co-opt the insurance companies and mandate that they do things that they don't want to do is not going to fly on the first step. But people are thinking about it. It's a good question, and it's a real problem. And again, the hand waving vigorously in the back of the room.
So to answer your question, just really quick, and there's been lots of discussion on Facebook about this, and it's kind of a scary thing, reaching out to your colleague and saying, would you put this patient's going to list you as your primary care doctor, would you write referrals if I let you know they need a referral? You got to have a really good relationship with that doctor, and they've got to trust you. Well, I have 2 in my area, thank God, because I've been there so long, and we've all covered each other. And they're like, no problem. I'll see them once a year.
They do have to see them and establish a relationship.
Yeah, they see them once a year. If it's something that's really serious, I will say just take a gander at them before you write the referral. But if it's something like a mammogram or, a skin check with a dermatologist, it just... That's kind of stuff they don't have a problem with, but they have one of my patients who does that broke her foot walking her dog, and she had to go. That required that she was like fine paying both. So on another vein, these HMO patients, some of them don't mind paying for DPC in addition to their HMO, and I have friends in Ireland. They tell me they have their national health. All of them pay for their private doctor. And the rates are so affordable with DPC that she's fine doing both. So.
Hi, I'm actually a specialist urologist. I'm from Ohio, and I have my foot in both ponds. And Megan and I know each other because I've been here on other occasions. It's really clear to me that it's time to move out of one pond and into the direct care arrangement, because the bureaucratic requirements and the administrative burden is just literally overwhelming. But my question is, how do you establish the fact that you're willing to participate in this direct approach to medical care, to the primary care? And in the state of Ohio, there is an area in southern Ohio around Cincinnati that's evolving, but I'm in Columbus, and they practically have a wire fence around that city relative to this, and I think it's time, and many of my colleagues feel it's time for that fence to come down. How do you make that connection? Our practice does have some specialty things that we worked with at a direct approach to referral and care and at reduced cost. But the bottom line is, how do you do that en masse?
Well, I've got one comment, and this is a radical thing, but it has to start, and it's not going to start all at once. It's not going to happen all at once, but really, if you're right-handed, it's here. If you're left-handed, it's here. It really boils down to the linchpin that holds the whole perverse system together is the physician contract with payers. Think about it for a second. If those went away, if you waved a magic wand and those all went away, everything would collapse, right? Prices would start to matter again. You wouldn't have these shenanigans and this shell game going on with prices. So if we did that, and you do it obviously one contract at a time, all of a sudden these plans are becoming more or less and less valuable to the extent of being worthless. So
Doctors have the power. It's a prisoner's dilemma, though. Nobody wants to opt out of the contract because the patient's going to go somewhere else. So I think there'll be a tipping point, but it really comes down to that, and it's as simple as that. And then at the same time, the other market grows simultaneously side by side with offering specialty services like you do.
What fence? I'm sorry. What kind of fence do you mean? Can you describe that more? I kind of know what you mean, but if
The hospitals and the insurance companies are so locked together.
yeah, that's how my area
There's
is.
very little room between the posts and the fence.
That's exactly how,
People through it.
yeah, yep.
So I think that as the direct primary care movement grows, I think that's how the specialty movement needs to grow along with it, because what you need to have are 1,000 primary care practices that are reaching out to their specialists and saying, I want your 20 prices on your most 20 commonly done procedures. Give me prices on your office visits. Tell me what it's going to be. And I have a list for my rheumatologist, my GI, my cardiologists, dermatology, and we have prices for everything, just to say what are my patients going to expect to see when they come to you. And it's got to start somewhere. But I think with some transparency in that market, that's I think where it needs to go.
How many of you
as
are
well.
independent in that area and aren't owned by the hospital? Yeah.
Primary care, is that what you're asking?
No, in general, within your fenced-in area, how many are independent between primary care and specialists, are not owned by the hospital or a
I
hospital?
would say it would be a distinct minority. I can't give you.
Well, that's how my area is. So one of the lovely things I've discovered with direct primary care is, despite me reaching out to specialists for cash pricing, I am finding that a lot of specialists I didn't have to directly reach out to already had cash pricing in place. I had no idea.
They need an outlet for
And
it.
of
They
course-
need a
Yeah,
demand
they need an
side.
outlet. So here I'm the outlet. Now they're like,
You could
wow,
reach
this
out
is
to
great.
folks like Ralph Weber and Medibid and put your prices out there. One last question.
I have a
Back.
comment, just to maybe help, but what we've done is for specialists, we do 3 things. Number one, my wife and I take the specialist out to dinner and his wife. And my wife has a sixth sense to tell if this guy's a good guy or not. That's number one. She has to pass the muster.
That's how women are.
Number 2, we go to the specialist and we say, listen, we will send you our patients, all right, our cash patients, all right, and we will give you we negotiate between 10 to 15% less than Medicare or Medicaid. But here's the catch. The patient goes knowing how much they're going to pay ahead of time, cash or credit card, or a check, and they come with, there's no billing, it's cash before they're seen.
Yep.
They all go for it.
Yep.
Every one of them. Number 3, what we do, you have to know your specialist, because what happens, we have a lot of, let's say GI, we had trouble with GI in our town. And, oh yes, cheap doctor, no problem. But then they'll ask for this test and this test and this test to bag up the bill. Mm-hmm. You want a doctor who you know has the same philosophy of you, and it works.
And they're out there.
It works.
They're definitely out there. Yep.
Yeah, that was also one of the issues that we had, because again, we have bundled surgical prices now for orthopedics, and the one doc that we had was an orthopedic surgeon. He wanted to charge $50 for the initial consultation. I said, no, make it $200. And he said, why $200? I said, because if they can't afford $200, they can't afford the surgery. I mean, so basically the initial office visit actually is a deposit towards their surgery. What we were having is people coming in for their $50 consultation, finding out the surgery was $3,000, and then not having surgery, and now the surgeon's starting to get pissed because he's seeing a bunch of referrals for $50. And before you know it, he cringes every time you pick up the phone and call him. So by raising that threshold to say, is this patient really wanting to have surgery? So let's go ahead and put a little money up front towards that surgery.
And people
it
are
seems
willing
to
to
stop
drive.
some of that
I'm
stuff.
sorry, excuse me. Go outside your fence. People are willing to drive for this.
Or
You don't
fly.
have to stay in the fence.
Or fly.
Yeah, or fly
About 5 more minutes
to
left.
Oklahoma City.
Yes.
Sure. So I'm actually not a doctor. I'm president of a healthcare tech company called UMA, and we are creating a free services or healthcare services marketplace, which sort of does what we're all talking about, and that doctors can sign up and list their prices, and we send them cash-paying patients, and patients pay upfront based on initial consultation fee, and then during the visit, if there's any like additional services tacked on to it, the doctor and the patient have that discussion, and then it's just tacked on afterwards once it's agreed upon. My question is, and we've been getting questions from other doctors, is there a risk of insurance companies sort of lobbying the hell out of Washington to sort of find out?
Stop you right there. Yes.
Yeah, so, I mean, yeah, and forgive me, I haven't had this discussion with anybody really yet, so sort of curious to hear your thoughts on that. And
Yeah, there's always risk. I mean, anytime you're, the one thing that stands out is I love the AV people in the room, but in most conferences, the guys usually sort of surfing the internet while we're having a conversation. We just put on a 2-day program in Dallas, and at the end of the conference, one of the AV guys came up and said, "Boy, I've been listening to you guys, and you know what? You're about to piss off a whole lot of people."
You don't get flack till you're over the target. I wanted to follow up on the question from the back about referring to the specialist, picking your specialist. Did you say so much below Medicare or Medicaid, or did you say above Medicare?
Everybody we get charged about 10 to 50% below Medicare or Medicaid.
Well, here's the question I would have, because in most specialists, if they're participating and they accept a fee less than what they get from Medicare, Medicare views that as overcharging them. So how do they get by with accepting less than their Medicare reimbursement?
Collecting it up front. It's not my business. It's their business. Collecting up front's the key.
You're collecting up front.
Yep.
I see.
That bypasses everything.
Oh, they discount it down and write it off, charge it up front. Okay.
And there's a form to sign. As long as they collect it up front, they can go below.
Got it.
We have time for one more, or we?
This poor guy's had his hand up.
Okay, I've been trying to get your attention for a while.
Sorry, I'm sorry about that.
So this is a primary care. So one of the issues then, how do you deal with the Medicare patients? Do you just drop them all? Or can you have a DPC practice for non-Medicare patient while still caring for Medicare patients if you so desire?
You cannot double dip, okay? So that's the key. I mean, MDVIP walks the gray line with that.
No, it's not double dipping. I mean, what I'm asking is...
I know exactly what you're asking.
Yeah, just taking care of a Medicare patients completely separately. They're not DPC patients, but also for, just cash-paying DPC patients, right?
Right. So my practice is a hybrid. I am membership only below the age of 65 and Medicare fee-for-service 65 plus, but I'm in Florida, the Medicare capital of the world. And we have no protective legislation in Florida. So, a cease and desist letter away from being out of a job. So we do that. We never charge a membership fee ever to a Medicare patient, ever. And we don't collect cash from Medicare eligible patients, ever. The challenge, I think, with a lot of DPC startups is they're going to need to do some moonlighting things, and when they opt out of Medicare right from the get-go, they lose a lot of their moonlighting opportunities. They can't go to the hospital, they can't go to the urgent cares, because your NPI number is what you opt in and opt out over. So your NPI number is the same whether you're working urgent care, moonlighting, and working in your practice. So you can't say, I'm going to go ahead and do a DPC here and then moonlight in urgent care, be opted out here and opted in there. That does not work. It's either all in or all out.
Unless they bill for you, but then they can only collect 85%. So a lot of moonlighting companies won't hire you because they're not going to be able to collect 100%.
So I think what we're saying is you can't have two agreements. You can't have an opt-out private agreement with some Medicare patients and then let some use their Medicare. I mean, you've got to do what Lee would do. And it's clear in my mind, it sounds fine because he has that age cap. Nobody above the age of Medicare is DPC, correct?
Yep.
Yeah.
And there are other hybrids out there that are just they don't want to give up their Medicare patients. It's not even just we see a lot of questions and comments about this on social media. They don't want to give up their Medicare patients. They're sad to do that ethically. So a lot of them are still keeping their Medicare as fee for service and doing DPC.
Almost all of mine have opted out of about 25% Medicare, maybe 20. All of them have opted out of Part B back when you could do that. And they have almost all of my 20% that are Medicare age opted out, and they have coverage via health sharing ministry type of program.
This has been a great conversation. I appreciate your questions. Appreciate you getting up early and coming out here. We are out of time for this panel. I know I'm here until Saturday afternoon, and I'm sure any of the folks on the panel will be more than happy to answer any questions outside of here. You have my contact information up there as well. Thanks, everyone. Have a great
Thank you.
conference.